Good morning, everyone. Lovely. Okay, so I'm going to be moderating our first session. We're just going over upper GI disorders. So it's my pleasure to introduce our first speaker is Kevin Ghassemi. He's the Associate Director of our Esophageal program here at UCLA, and he's a hell of a good guy. So he's going to talk to us about GERD and dysphagia.
All right, thank you, Ravindra, and good morning, everyone. It's a pleasure to speak to you bright and early. So this is supposed to be a case-based conference, so I want to start off with a case and get your minds thinking. So this first case is a 31-year-old lady who has experienced almost daily heartburn and regurgitation occasionally for the past year. She does not have any nausea, vomiting, or any prolonged postprandial fullness. There's some mild improvement when she was taking omeprazole 40 milligrams a day. And when the dose was increased by her primary care doctor to twice a day, she felt that she was 50% better. She got referred directly for an upper endoscopy that showed a 1 centimeter hiatal hernia, but there was no evidence of esophagitis. And this was done between the once a day to twice a day change. And she's really concerned about long-term PPI use, and so she's asking you, what should you do? So you guys should have these audience response clickers, and so your choices are A through E: add an H2 receptor antagonist at bedtime, send her for another endoscopy, perform pH testing, send her to be evaluated for anti-reflux surgery, or just tell her, hey, the endoscopy was normal and she's already on a high-dose PPI, so just stick with it. So all right, so more than half of you suggested the H2 receptor antagonist at bedtime. Okay, so whatever you pick, keep it in mind. I'm not going to answer the question right now. I want to keep you in suspense until the end. Okay? And now that you kind of know the format of these cases and how to respond, let's do one more case so you have a couple of things to think about as we go through this talk. So here's a 53-year-old lady with a 7-month history of a chronic dry cough. It occurs sporadically, and there's really no correlation with meals. She does have some mild postprandial heartburn that preceded the cough. It occurs once or twice a week, doesn't take anything for it. And she ended up getting referred to a head and neck physician who did a laryngoscopy, and the report comes back saying that there's evidence of Laryngopharyngeal reflux, or LPR. So the ENT doctor recommended that she be on a PPI twice a day for 6 months, and she comes back and sees you 4 months later, following the instructions, but has not noticed any improvement in the cough. So what should you tell her? Refer for EGD. Tell her she has to wait the 6 months like was recommended before doing anything else. Suggest that she avoid acid reflux trigger foods or high acid foods. Send her for a pH test off acid suppression, or just tell her she's nuts. Send her someone else. All right, so send her for an EGD. Okay. All right, again, keep that one in mind. And with that, we're going to do a little bit of didactic. So this slide here is to show you that GERD is very common throughout life. This graph shows a whole bunch of studies, and as you go across the timeline in age, the prevalence pretty much stays the same. So this isn't just something that affects older people or younger people. It's everyone. Now, there's a variety of mechanisms by which reflux can occur. You can have dysfunction of the lower esophageal sphincter, poor clearance of the esophagus or dysmotility, a hiatal hernia, anything that increases intra-abdominal pressure, such as being overweight or weight gain, and delayed gastric emptying. So the variety of ways that reflux can occur. Now, when we think of reflux, we think of the typical symptoms of heartburn and regurgitation, but typical is becoming less typical nowadays, at least in our gastroenterology practices. People may present with chest pain or dysphagia. What we consider atypical symptoms are nausea, dyspepsia or bloating, and belching. Just keep in mind belching is reflux of gas. And then there's a variety of extra-esophageal manifestations of reflux, including cough, laryngitis, globus pharyngeus, or a sensation of a lump in the throat. Asthma, about a third of patients with adult onset asthma can have it attributed to reflux. Dental erosions, pharyngitis, sinusitis, pulmonary fibrosis, and even otitis media, although that's much less common. So just a little bit on LPR, since our second case was about that. This is what an otolaryngologist will see. At the top left, you have normal. Vocal folds are nice and white and no erythema. But then at the upper right, you have true vocal cord erythema, as pointed out by now 2 arrows. And then more subtle, there's this arytenoid medial wall erythema. And then finally, posterior pharyngeal wall cobblestoning. Now it's actually funny, in medical school and internal medicine training, the cobblestoning was always a sign of postnasal drip. So I found it kind of interesting that ENT doctors would immediately jump to this being reflux. But how helpful are these signs? So as you can see from this table here, comparing normal patients as opposed with those who truly have reflux, the first two, the posterior cricoid wall erythema, which I didn't show you a picture of, is actually much more common in reflux compared to normals. But the cobblestoning, you can tell that there was no significant difference. And then really the bottom two are the ones that are reported the most by the ENT doctors, the cord erythema and then the arytenoid medial wall erythema and edema that seem to be more specific for reflux. The problem is none of these findings are pathognomonic. You see some redness doesn't mean that it's reflux, it just means that there may be some irritation. And actually there have been studies that have shown that people who were diagnosed with LPR then underwent standard pH testing to look to see if there was reflux, and most of them actually didn't have reflux. Keep in mind, if you're going to have LPR, you have to first have esophageal reflux. It doesn't skip anywhere. So going on to treatment for reflux, the mainstay is PPIs, and there's a variety out there. The effect of the medication, though, depends on activation of the proton pumps, which is coming from meals. So to tell your patients to take it at bedtime, it doesn't mean it won't work, but you'll get the most bang for your buck if you tell them to take it about a half hour before they eat a meal. And the reason for that is the half-life for these different medications, it's about a few hours. The shortest one, pantoprazole, I think is less than 2 hours. And so if you take it at nighttime and they've already eaten long ago, or they take it in the morning and then they skip breakfast, most of it's going to have been metabolized and passed out before it actually does anything to with the pumps being activated. The one exception to this is the dexlansoprazole, which is a dual-release medication. It's essentially BID dosing in a once-a-day tablet. And so there's that second set of absorption in the distal small intestine. There's very little difference in the pharmacokinetics. Actually, it's just about the half-life. Otherwise, it's pretty much effective. There's no real significant clinical relevance. Although I will find occasionally patients who say, you know, omeprazole didn't work, but lansoprazole did. And we really don't have any pharmacologic explanation other than there's maybe something idiosyncratic or specific to that person. There have been some studies that suggested that esomeprazole had a 4 to 8% higher healing rate for erosive esophagitis. So erosive esophagitis, though, is relatively uncommon compared to non-erosive esophagitis. So this slight difference may not be all that significant. To me, in the end, the one that's cheapest for the patient, whether it's covered by insurance or now most of these medications are available over the counter, so insurances don't cover it. So whatever ends up being the cheapest and yet still works is the right one for them. The newest isn't necessarily the best. Now, as with our first patient who had some response but not complete, you have to think about, well, maybe the diagnosis is right because they are responding to some degree, but either there's a problem with the way the treatment is occurring or there may be something that's hindering the maximal effect of the medication. So make sure the patient is taking it at the appropriate time, again, about 30 minutes before a meal. And if it's twice a day, it's, say, before breakfast and dinner. Maybe they need a higher dose, which we'll talk about. There's the concept of nocturnal breakthrough, and then also inadequate control of lifestyle issues. Coexisting disorders include a hiatal hernia, which you can see here on the right with the endoscope in retroflexion. This area right here is the diaphragm, and there's stomach further up, meaning that some of the stomach has herniated into the thoracic cavity. Delayed gastric emptying or gastroparesis, and then some kind of underlying esophageal dysmotility, such as scleroderma. So talking about dosing of PPIs, for most people, a once-a-day dose will actually provide good 24-hour relief of symptoms. But about 20% of people who are partial or non-responders to once-a-day dose will actually find better relief with twice-a-day dosing, and again, before meals, not taking it at night. Concept of nocturnal reflux. It's actually seen in about 30% of people, but the relationship is not really clear because we may see nocturnal reflux based on a pH study, but patients are complaining of symptoms during the day. Does that mean then that the nighttime reflux is causing the daytime problems hours later? It's hard to tell, but so the studies are unclear. So what's the role for the bedtime H2 receptor antagonist? So you can use either the famotidine 40 milligrams or the ranitidine 300 milligrams. That's high dose. And it's been shown that about 70% of patients will have additional improvement compared to the PPIs alone. But there is the possibility of developing tolerance, and this is seen more so when used alone because you're only blocking the histamine receptors for acid stimulation, whereas the PPIs will block the final common pathway for acid output. So using using H2 receptor blockers alone, that's really where the risk of tolerance develops. And then lifestyle modification, anything that you can do from a lifestyle standpoint that can significantly reduce symptoms makes sense. Of course, weight loss has multiple health benefits, but anything that reduces the intra-abdominal pressure can help reduce reflux symptoms. Usually lifestyle measures alone, particularly weight loss, while it may improve symptoms, may not necessarily get rid of the reflux. I've seen plenty of patients who have had severe reflux esophagitis, yet have little to no heartburn. So there is a potential disconnect between symptoms and findings. Smoking cessation based on its effects on esophageal motility and the LES. A great one is to tell them not to eat within 3 hours of lying down, particularly at night, especially for patients who complain of nighttime symptoms. And then with regard to dietary triggers, it's actually really restrictive to cut out all the acidic foods or all the known trigger foods. And what I recommend to the patients is, if you find that there's something that clearly causes your symptoms to get worse, avoid that or cut down on that. They don't want to cut out coffee, but maybe 1 cup of coffee a day is enough to get their kick and at the same time not have such bad symptoms. Just want to touch upon this concept of non-acid reflux. So we think about reflux as being an acid-mediated process, and for the most part that's true in terms of its injurious effects and symptoms, but the PPIs, all they're doing is taking the acid out of the refluxate. So it's still possible that the presence of the fluid, particularly for the extra-esophageal symptoms, may be bothersome. And so if this is something that you're concerned about and you have a patient who has known reflux, it's been previously confirmed, the way to test for this is what's called an impedance pH test. It's a dual test that measures for acid reflux, but it also looks for a drop in resistance as a marker of reflux occurring, and then the pH component will tell you if it's acidic or non-acidic. Treatments for this are somewhat difficult. The only medical treatment that can be considered is baclofen, particularly if you have the LES frequently relaxing, but that's quite limiting based on side effects, particularly drowsiness. So most of these patients, if they truly have non-acid or just reflux causing symptoms despite the PPI, they may need to be considered for surgery. So this is a pretty busy slide, but this is an algorithm that's actually recommended by a GI working group for pH testing, because the question is, well, should you test the patients on PPI or off PPI? Should it be impedance, or do you not need to have the impedance? And really what it comes down to is, number one, has the person ever been confirmed to have reflux? It's very common we give PPIs for abdominal pain, a variety of symptoms, especially if we're not sure exactly what's going on, because if they get better with the PPI, it suggests that there was probably something acid-mediated. But if they're not getting better and it's been weeks and weeks and weeks, you kind of have to wonder, is this really what's going on? So the first thing to do is confirm if they have reflux. So you start by getting some type of pH test done off of PPI. Determine if they have reflux to begin with. And there's 2 types of tests. There's a catheter-based test, which goes through the nose. It's a 24-hour test. It works, but it's certainly not pleasant for the patients overall. And then there's the wireless pH testing, which is a 48-hour test. It's a little probe that's placed usually endoscopically just above the LES. And then 48 hours, it's transmitting information to a recorder that you wear around your belt or hang from your neck. and then the recorder is returned, and then the probe will fall off several days later. The patient passes it out, and they can save it or flush it down the toilet. So that's the testing that's available. Now, so how do we follow this algorithm? Well, if you test them off PPI and they have normal acid exposure, a normal test, it's unlikely that they have reflux. So then you have to determine, are they having the typical symptoms like heartburn and regurgitation, particularly heartburn? And if they do, this is more of a functional or visceral hypersensitivity called functional heartburn or non-cardiac chest pain, depending on the symptom. If they have extra-esophageal symptoms, sore throat, hoarse voice, respiratory problems, you got to look for another diagnosis, not necessarily in the GI realm. On the other side, if they do have acid exposure, then it's very suggestive that they do have GERD. So you really want to make sure that you're doing everything you can to optimize the treatment options with the PPIs. And at that point, if they're still not responding, you can consider getting an impedance pH test with the patient staying on the PPI to see if, number one, is there breakthrough acid reflux? Are they having a lot of non-acid reflux? And then also you can look for an association between the symptoms and reflux to help distinguish if they're more of it's a sensitivity problem, or this is not an issue whatsoever. So the bottom line, I think, to take away from this slide is if they've never been confirmed to have reflux, confirm that they have reflux. So now we'll talk about anti-reflux surgery. This is an option for long-term control of reflux, and it's been shown to be as effective as medical therapy. And the people who respond best to this are the ones who have great response to PPIs. You know that the anti-reflux surgery is going to work. There may be a role for partial PPI responders, as we'll talk in a moment. And before you send them to surgery, they need to have the appropriate evaluation because surgery doesn't work for everyone. So what is this preoperative evaluation? Basically, you need to make sure that they have reflux, so some type of pH test, and you need to do an esophageal manometry because what the surgeon can do to physically block the reflux can cause dysphagia if their esophagus isn't working well to begin with. So this is a picture of that wireless pH probe I talked to you about, and then this is a high-resolution manometry. This is a normal swallow showing peristalsis. And really we want to make sure they don't have achalasia, a motility disorder. They don't have scleroderma because if they do, that's going to make their dysphagia a whole lot worse. And if they didn't have it before, they will have it. And then eosinophilic esophagitis, which is like an allergic condition of the esophagus, one of the symptoms of which is heartburn, and also dysphagia is a common one. So there's two general surgical options, the fundoplication, as you can see here, and we'll talk about that first. There's three types of fundoplications, just so if you hear the terms, you know what we're talking about. There's the Nissen fundoplication, which is a 360-degree wrap. The Dupé, which is a 270-degree wrap going around the back of the esophagus, and then finally the door, and that's not a misspelling, that's an anterior 180-degree wrap. The last one is used more so when you're treating achalasia. It doesn't have that much anti-reflux capability. It's very minimal. So I told you that fundoplication or anti-reflux surgery works really well for people who have a good response to PPI. And this was a study that was done in 2011 looking at people who had extra-esophageal symptoms because we didn't know necessarily how well it would work for these people. So this was a really good study. What they did was they looked for predictive factors of success in people who had extra-esophageal reflux, particularly throat symptoms like cough and sore throat. And so they underwent all the standard testing, and what they found was the best predictive factors for extra-esophageal reflux were if you had also typical symptoms such as heartburn, and you had an excessive amount of reflux more than 12% of the time. 90% success, so pretty predictive. Now, if they only had one of the two testing findings, so if they had here an abnormal pH test but no heartburn, it was about 60% effective. A little bit less effective if it was the reverse, meaning they had heartburn but a normal pH study or not significant reflux. And then finally, 10% success if all they had was the extra-esophageal symptoms. No evidence of reflux on testing, no typical symptoms. So not everyone with throat symptoms who's told that they have reflux will get better with an anti-reflux surgery, meaning that it may not all be reflux. Plus, surgery is not a benign thing. It's not going to make people 100% better. They may feel better, but it has its risks and potential complications, most common of which is the gas bloat syndrome, especially seen with the fundoplication. You're strengthening the gastroesophageal junction from acid coming out or reflux coming out, but it also can prevent air from coming out. A lot of patients can say that they don't feel the ability to belch, or they may have difficulty vomiting, which may sound good, but it's nice to have that ability for catharsis. Dysphagia is very common early on. It usually gets better by week 12, and that's again why it's important to make sure that esophageal motility is in good shape. And diarrhea is actually seen in a higher number of patients, primarily because they're unable to belch or vent anything out. And it's not perfect because although this is a fairly high range for the recurrent heartburn, it's more on the order of about 10 to 20% of patients might still need to take PPIs. So again, not perfect. Last one I want to talk to you about is the sphincter augmentation device for the LES, which is this string of magnetic beads here. And what's nice about it is it can be placed laparoscopically and is about 30 minutes or even less, so you could get your pizza right afterwards. And it's supposed to strengthen the LES tone. And so the magnetic forces are strong enough to prevent reflux, but in good esophageal function, there's enough bolus pressure from what's swallowed to open up the magnetic beads, as you can see here, to allow the bolus to pass through. This has been shown in studies that are now dating out to 6 years. This is relatively new technology, that this technology allows for belching and vomiting, so we see less of the bloating than we do with the fundoplication. But it is a foreign device, and it's advised at this point in time you can't get an MRI if you have this, just like you have a pacemaker, although that's changing, so maybe this will change in the near future too. All right, one more case, and then I want to talk about the dysphagia aspect of things. So this is a 68-year-old man who has had a progressive cough while eating for the past 2 years. He feels that solids have more of a problem going down than liquids, but sometimes he gets pills stuck in his throat, and the bolus will either come up immediately or he has to cough it up. Over the past 2 years, he's lost about 5 to 10 pounds unintentionally. He has really no other symptoms, and he's tried a once-a-day PPI without any help. So what do you think is going to provide the diagnosis? Endoscopy, esophageal manometry, an upper GI series, modified barium swallow study, or pH test? All right, so about 2/3 you said either endoscopy or a modified barium swallow study. All right, keep that in mind. We're almost to the end. We'll come back to these cases. So there's a pretty wide differential for dysphagia. You can break it down initially to whether this is an esophageal type of problem or if it's more oropharyngeal. And then under esophageal, you can break it down into an anatomic or structural problem versus motility. So you should all have this in the syllabus. I'll leave it up here for a few seconds. Under esophageal, very common are acid reflux related conditions, including peptic stricture, Schottky ring. Eosinophilic esophagitis is growing quite quickly, based mainly on recognition, especially in younger patients. Let's see, achalasia is always very commonly thought of, but is relatively uncommon. And then with oropharyngeal, you have a variety of structural problems, and there can be some autoimmune or functional problems as well. So if you have someone complain to you of some swallowing problems in the clinic, what can you do just based on history to try to figure out where it might be occurring? So I'd put in a few factors here on the left that you can consider asking that might help you to figure out what tests to get to better figure out what's going on. So for localization, if patients have oropharyngeal dysphagia, they'll usually say it's occurring in the throat. However, it's not that helpful for esophageal dysphagia because patients who may have a stricture in the lower esophagus can actually still feel stuff building up here. So localization is not that great. How about timing relative to the swallowing bolus? This is much better. If they say it occurs immediately, it's most likely oropharyngeal or in the upper esophageal sphincter area. Whereas if they say, yeah, I swallow and then just a few seconds later is really when I feel it get building up, that's more likely to be esophageal. Coughing may be associated with oropharyngeal, usually not so much with esophageal. And then chest pain, you're not going to expect that with oropharyngeal dysphagia. You may or may not with esophageal dysphagia. So history can be helpful. So these would be the questions, particularly the timing that is the most helpful. But you can ask all of them because sometimes even localization can be helpful, but less so for esophageal. So what do we do to evaluate? Well, endoscopy should be performed in all cases where it's suspected that the dysphagia is coming from the esophagus. You want to make sure that there's nothing malignant or pre-malignant going on. And of course, endoscopy has the capability of providing therapeutic intervention, whether that's dilation, injection of a drug, or placement of a stent like my colleague Dr. Watson does. So here's a Schottky ring. Here's a peptic stricture. This is the ring seen in eosinophilic esophagitis, and this is bad. Esophageal manometry is primarily used to diagnose a motility disorder, and we think of achalasia again as the typical esophageal dysmotility, and this manometry is necessary for its diagnosis. It also helps with subtyping the different forms of achalasia because therapeutic interventions are not all equal, and different subtypes will have different response rates. And this is complementary to barium studies when you're trying to look at disorders involving the cricopharyngeal muscles and the upper esophageal sphincter. So fluoroscopic evaluation can be very helpful, and reality is there's really never a wrong time to get this test. You may not always need to get it, but it can provide useful information. And there's different types. There's the traditional esophagram or barium swallow, which the focus is on the esophagus, as compared to an upper GI series, which looks at the esophagus, stomach, and small intestine, duodenum, and spends very little time focusing on the esophagus. So if you're concerned about dysphagia, get an esophagram. Modified barium swallow study is really helpful for looking at bolus transfer and potential oropharyngeal causes of dysphagia. This is performed in the radiology suite by a speech pathologist, and they use different bolus consistencies to see if there's a different process going on with solids versus liquids. Any of these fluoroscopic evaluations, they can look for anatomical abnormalities like a ring or stricture, the bird's beak appearance with achalasia. You can look for a cricopharyngeal bar, which is what's seen here, that little black indentation into the esophagus. And then it does provide some functional assessment of the sphincters, particularly. So the treatment really depends on the underlying cause. You can dilate or put a stent if you have a stricture, but you want to treat the underlying disorder, so PPIs if there's reflux, and there's a variety of treatments for eosinophilic esophagitis, including PPIs, specific food elimination diets, and then topical swallowed steroids. For achalasia, myotomy is the most definitive treatment, which can be done laparoscopically, but there's also balloon dilation and injection of botulinum toxin, makes the esophagus look younger. And then for spastic disorders, there's a variety of medications, including calcium channel blockers, nitrates, and even peppermint oil has been shown to treat the manometric findings in spasm as well as symptoms. For a cricopharyngeal bar, as you saw the picture before, this can be dilated, or a myotomy can be performed to open that up. And for a diverticulum, Zenker diverticulum, which is seen in the upper esophagus, you can either remove the diverticulum surgically, or a myotomy can be performed so the diverticulum becomes very wide mouth and essentially asymptomatic. All right, so you remember your choices. So case one was the lady who had the persistent heartburn on PPI. So I would say actually refer her for anti-reflux surgery evaluation. Now, I'm not saying that she's going to need surgery, but she's going to get the testing that she needs to determine if surgery is appropriate or if there's something else going on. So that's the pH study and the esophageal manometry. For case two, the lady who had the cough that didn't respond to the PPIs. So I would have recommended the pH study off of PPI to determine if she even has GERD to begin with, because she was told she had GERD, but symptoms didn't really get better, at least with regard to the cough. And yeah, she did have some heartburn here and there, but it wasn't a daily occurrence for her. So the endoscopy would not have been recommended, because I think that's what most people chose, because in this case, really the primary symptom is the laryngeal symptom, and our society guidelines recommend that that's actually not helpful because it's so low yield. And then finally, for the most recent case, the gentleman who had dysphagia and coughing, so I would have recommended the modified barium swallow study, as most of you did as well, good job, because this can look at oropharyngeal, cricopharyngeal, and proximal esophageal pathology, which is really where it sounds like the symptoms were originating from. So with that, I want to thank you for listening and hopefully enjoyed the cases, and I'll take questions at the end of this session. Thank you.